All right, I think we can start. So my name's Minnie. I'll introduce myself in a minute. And I'm very happy that Agora have invited me to do this workshop on multiple comorbidities and autoimmune conditions. And I'll be doing this alongside Andrew today, okay? Before we start, because this will be a workshop format after we've both spoken, I just thought it would be nice to know each of your names and countries, just so that I can maybe tailor it a bit better as well, depending on your background. So just name and country, and then we'll get stuck here.
Estonia.
Thank you.
Jelena, Serbia.
Meribela Martin. Eva, Estonia. Marcela Marin from Greece.
Marina from Italy.
Colin from Portugal.
Ivanka from Bulgaria.
Ram from Israel.
Rebecca from Italy.
Thank you. All right. It's okay. I can shout, you know, instead.
This is for the recording. Okay.
Yeah, I know. Okay, thank you. All right, so a little bit about me, just so you know which angle I'm approaching this from. So I'm a doctor in rheumatology and internal medicine working in King's College London. So I work with Eleanor Nikiforu, who is my social determinants of health with a focus. I'm also the EMUNET, so Young Rheumatologist Representative to ULA PARE. I've previously chaired the social media committee for EMUNET, and I have various involvement with national and international guidelines, particularly with ULAR. So today we're going to try and understand briefly the overlap between multiple autoimmune conditions and comorbidities, discuss the impact of that, and that's really the bit that I want to focus on, and then share practical strategies together on how we can best cope with that. I think this will be quite nice because I am going to be repeating a couple of concepts you've already heard over the last 2 days, but hopefully there will be some building on that repetition as well. So, firstly, what do we mean when we say multiple autoimmune conditions? So, basically this means 2 or more autoimmune diseases in the same person. So, some common examples that I see in the people that I see in clinic is someone may have rheumatoid arthritis with thyroid disease, or lupus with Sjögren's. Sjögren's can happen alongside many other autoimmune diseases. And psoriasis with psoriatic arthritis. So this is almost, it's multiplying the impact, it's multiplying the burden, and that's what we're going to be talking about today. And it can affect approximately 25% of people, at least, are living with 2 or more autoimmune conditions out of the people who have autoimmune diseases. So why do they occur together? Well, we don't know, but some possible explanations for this are shared immune pathways. There is a little bit of a genetic and family risk as well. We do know, as we've heard already, that there are environmental triggers, so stress being a key one, as we were just talking about. Infections can sometimes play a role, and other triggers such as smoking, cigarette smoke, or pollution as well. And also one condition may increase the risk of another, and we do see that, for example, with lupus, antiphospholipid syndrome, rheumatoid arthritis, Sjögren's. There's many examples. This is just a diagram from one of mine and Eleanor's papers, which just kind of summarizes everything I've just said. So you can see I've got somebody in the middle as an example who's got inflammatory arthritis, and they may, so you can see they've got lung disease, they may have osteoporosis, they may have heart disease, and feeding into that. So, and many things that are helping that and maybe hindering that as well. So the amount of social support someone has may impact how they experience their comorbidities. things like gender, race, things that we can't change, those ones are also going to impact the person's experience. Lifestyle, employment, smoking, like all of these things feed into that person's experience of living with these diseases. And then your biological factors at the bottom, so things like the stressors, the genetic parts of it, and the immune responses. So you can see there's multiple things that are feeding into this, and this is why it's very difficult to manage the multiple conditions, but we are going to try and talk through some ways to do that. So I've already mentioned this term comorbidities, and just so that we're on the same page, so I'm just going to define the word comorbidity. So the comorbidity is the now existence of any additional condition or disease during the clinical course of the main disease of interest. So, for example, if a person has rheumatoid arthritis, any other condition that they have, that would be considered a comorbidity. We do know that the number of comorbidities increases with age, the duration of having an RMD, and also disease activity of the RMD can play a role in the development of comorbidities. Again, this is a slide from one of our papers, and in this diagram we were just trying to highlight the fact that if we look at the left, a lot of people, particularly clinicians actually, I'm quite happy to say that, a lot of clinicians will consider for example, the rheumatoid arthritis, and then all of the comorbidities are sitting kind of outside. They're in the periphery. What we want to do is we want to make sure that the person is in the middle rather than the disease, and then all the comorbidities are the things that are surrounding them. So we try and consider it in a person-centered approach, and that is what we feel would improve the care and the holistic care of that person. My specialty is inflammatory arthritis, so I've talked a lot about inflammatory arthritis, but this is an example from lupus. And so you can see, a person with lupus, they may have the comorbidities on the left, so there's many different things that can happen in lupus, either related to the condition or related to other external factors. And then, of course, you've got all of the things that come with the treatment. So examples that you may have personally, experienced, maybe infections, heart problems such as hypertension, and I'm going to talk a little bit more about this in a minute. Osteoporosis, of course, from long-term steroid use, and other aspects which may not be spoken about, such as the reproductive aspects, which I know there's a lot of taboo in clinics to talk about that, but that's equally important as well. Right, sorry, I'm throwing a lot of terminology out at you, but it's important to get these clear. So there's another term which you may have come across or your doctor may have used, which is extra-articular or extra-musculoskeletal conditions. So what are these? So these are conditions which are seen mainly in inflammatory arthritis, such as rheumatoid, AXPAR, and they are thought to have the same immune mechanism, so not different immune mechanism, but same immune mechanism as the central disease process. And they're seen as just as challenging as the joint disease. And it's where the inflammation then goes and affects another part of the body. So here are some examples if we look at rheumatoid arthritis. So if we take the lungs, interstitial lung disease we're picking that up more and more now, so it is fairly common in people with rheumatoid arthritis. Vasculitis may occur in someone with rheumatoid arthritis. You can get the skin rashes, nervous system problems like a peripheral neuropathy where you lose your sensation in the hands and feet. Many different things can occur. And really it's about getting on top of, together with the patient, on top of the rheumatoid arthritis in order to best manage all of that. And identifying it as well, identifying those conditions. And then finally, the final category of conditions would be the problems that arise due to treatment. So I touched on this before on the slide on lupus. We know that there are an increasing number of effective treatments for RMDs now, but they all come with side effects. And that can also bring real burden to the person who's using the treatment. So it's important to have a very open discussion with your clinician at the very beginning about what those side effects may be, how to best manage them. So I've given the example of steroids, which is the most common treatment that causes all of these. So I've just put a few examples up. So Weight gain is the one which probably troubles the people I see the most. Osteoporosis and bone thinning, problems with eyes and cataracts, skin problems. The list is endless. And so it's really important to have like a good conversation between the two individuals who are in the clinic to try and come up with a plan for reduction of things like steroids or like even alternatives, and try and getting people off steroids if possible, where possible. So the impact of comorbidities, this is the only slide I have with like data and numbers, but essentially I thought I'd give the example of difficult to treat arthritis. You can see that if someone has at least 2 comorbidities, they are 69% likely to then have difficult to treat arthritis compared to the people with non-difficult to treat arthritis. So that's quite a big difference. It's almost double. Fibromyalgia. If you have non-difficult, so it's normal, rheumatoid arthritis that's under control, 9% of people in this population had fibromyalgia. Those were difficult to treat, that jumped up to 38%. And the pattern is the same throughout. So depression levels are higher, anxiety levels are higher. Osteoarthritis is a little bit higher, and having coexistent gout as well in this population was higher. So it's really important to identify the comorbidities and treat them as well as we can to stop these kind of things from happening. So now we're going to the section which I'll try and gloss over the bits that we've already covered in a lot of depth. But this is really important to talk about. So the comorbidities clearly have a huge impact on our daily life. We have more symptoms, appointments, medications. There is a lot more fatigue. We do know that people with more comorbidities suffer more with fatigue and pain, both emotional pain and physical pain. And it's unpredictable and it's invisible, and that then has a social impact as well. It takes a huge emotional toll. So there's stress, there's frustration, there's uncertainty, and then there's the practical challenges. So dealing with work, explaining all of this to your work, family, and navigating healthcare systems, depending on what the healthcare system is in your own country. But that can be really frustrating for some people. What we really want to see is better coordinated medical care. So really what I would like to see more of personally is better communication between rheumatologists, primary care doctors, and specialists. Yeah, no matter how hard I seem to try personally, there is always an issue somewhere, and I'm sure that's duplicated in many medical systems. It's not just the UK. Regular reviews should be done to try and avoid duplicated treatments. The number of times I've seen someone I've just given steroids to, the GP then gives steroids to as well, and a lot of our patients, they're a bit older, they may not be able to understand fully the effects of their medication, and those kind of treatment errors can occur really easily. So this needs to be avoided. And then screening for those adverse effects that I told you about earlier, particularly to do with steroids, checking how is someone's heart health doing, their bone health, their mental health, which is a really big issue for people living with RMDs, and often these things get forgotten about. So it's really important for clinicians to take note of that. And again, this just summarizes, we did some research on this, Eleanor and I, and really we spoke to about 20 patients and 20 clinicians, including healthcare professionals as well. And this is sort of the ideal picture we would like to see based on what both parties told us. And it was really interesting because both sets of people told us the same thing, but actually in practice, it just doesn't happen. And so really, as I said before, we want to keep the patient in the center, the close people around them, including families and carers who do also often get forgotten about. And then there is this wider team that we just need to be aware of, and as clinicians we need to be referring to much earlier, maybe before even we detect that there is a comorbidity or a coexisting condition. So this is where patient empowerment comes in. I can't remember who said about this yesterday, but I do remember seeing a slide on this yesterday. But the definition of this, and this is important, is a process through which people gain greater control over the decisions and actions affecting their health. And I'm quite passionate about this because I've said a lot of things that I would say if I was giving a lecture to a group of doctors or clinicians. But how can you help yourselves, essentially? Because not every doctor is going to just bring this out and talk about these things. So patient empowerment involves essentially understanding of your role as the patient, acquisition of sufficient knowledge, a facilitating environment, which is not always present, but we would like to hope that, we are giving a facilitating environment to have these conversations, and also equipping patients with the skills right from the word go that they know that they can have these conversations with their doctors. The first thing to remember is that you are the expert in your condition and your experience counts. And therefore, if you feel that you're not being heard, it's very important to ask questions, speak up if something does not feel right to you. This is where support groups, patient organizations come in, and they can be very, very helpful in supporting you. And obviously getting involved in research and advocacy, it's not an option for everyone, but it is important. And obviously the work that groups like Agora do is vital in that. And then I can't really talk about anything really without mentioning self-management because Eleanor is my supervisor. But this is very important here as well. Peer support, self-management education, and something known as health coaching, that can happen sort of passively or actively. That helps in managing your multiple conditions. This is just a snapshot from Eleanor's guideline on self-management in people with RMDs. You can read it on the EULAR website. There is also a lay summary as well. But essentially there was 3 overarching principles. Self-management is taking an active role in learning about one's condition and in the shared decision-making process. Has a positive effect. We know it has a positive effect on living with an RMD, and patient organizations are central to that as well. But what does that mean practically? So I've shown you a table, I've shown you some principles, but actually practically what do you need to do? So these are just some tips that I tell my patients. So keeping a health diary, or if you use an app, like tracking any symptoms that you had or things that you had to do on a certain day to manage your symptoms, that can be really helpful because you think you're going to remember something, but when you come to see me, you won't remember it and you want to tell me. So really important to track things, particularly when you have multiple conditions, because then it's easy to forget maybe, what was flaring on that day or what did you feel was not quite right that day, and then, everything just mumbles into one. Tracking symptoms and your flares is also really helpful. There are new, we heard from the, pain consultant yesterday who was talking about wearables. Wearables are now coming into, and digital health, into this space, which is hopefully going to make a difference, but we're not there yet. But tracking symptoms just in a diary is very helpful. Prioritizing rest and pacing. I know a lot of people here, I'm sort of preaching to people who maybe don't want to rest necessarily, and you're all very active, but resting is vital, even if it's not physical rest, but mental rest as well. We do know that stress contributes to flares of diseases and also just generally feeling unwell, particularly when you have multiple conditions. So this is vital. And also getting to know your body and recognizing what the early warning signs are. So you can then tell your friends, you can tell your workplace that, look, there's a flare coming, or I'm not feeling so well this week. You know what's coming before it reaches a point where you've hit the wall. Lifestyle approaches, I'm really going to do this very quickly because you've had lots of talks on nutrition and lifestyle already, but movement, gentle exercise, we had a long conversation yesterday about how best to do that, and coaching, but what works for you essentially in a safe environment. Nutrition, avoiding extremes particularly, and mental health is extremely important for everyone. So again, what works for you essentially. Practical tips, again, which I tell my patients is, as I said, sort of bringing written questions to appointments. I think that's the most important thing, because something will happen between your appointments. You have a question and then you forget it. And really just write it down and bring it to your doctor. I personally don't mind having a list put out. I know some people don't like it when someone brings out a list and there's this long list of questions, but I like that because it helps to bring structure to the appointment and it means I can prioritize those 10 minutes. Keep a medication list with you at all times because again, we forget things. Using reminders for medication and rest. This is an important one. So if you do take multiple medications throughout the day, a lot of you probably already do this, but setting alarms using an app, and also setting an alarm and using an app for, I'm going to take a rest at 3 p.m. I'm going to stop. And that's a good thing to do. People have told me that I should do that for getting up from my computer because otherwise I'll sit there for 3 hours. So it's, whichever way you want to use it, it's a very good thing to do. And sharing your needs with those around you to try and get the best support possible is also really important. Just look at the time. Okay. So looking ahead in this space, what's going on? So we do know that more research on overlapping autoimmune conditions specifically, because I've sort of flitted between the two, autoimmune conditions specifically is needed. So investigating those shared mechanisms and why conditions cluster together in the way they do, which will then help us better recognize them earlier and therefore manage them better. We want to go towards personalized care. That's kind of been a theme in this conference. Personalized care is kind of where we're going, but we're not there yet. So using risk scores, biomarkers, hopefully digital tools in future to help tailor monitoring, tailor treatments. And really, I think this is like the most important one, trying to integrate care between the specialties. So I'm involved in quite a few multidisciplinary clinics. So I do one clinic a month with dermatologists. There are clinics going on in my hospital with respiratory physicians, and they're becoming more and more common in several countries. So I think this is the way we need to go. And also sharing records and coordinating our care pathways to reduce that fragmentation and improving quality of life ultimately. That's what we're aiming for. So, multiple autoimmune conditions are common. Managing them is about teamwork. Small strategies like the ones I've mentioned can make a huge difference. And living well is possible even with complexity. Okay? Thank you. I'm happy to take any questions, maybe after the workshop, but I'll let Andri maybe speak now. Okay? Yes. Oh, yes. I don't want to break this. Professional. I can't see what's going on there, so
Okay. Good morning again, everybody. I will not make any presentation. I will just say you my story, my personal story, because I am living with a lot of comorbidities, and this is for me. At times are hard, but are times that I manage to go on with them. Okay, I am diagnosed with axial spondyloarthritis since 2003. I used to have symptoms from the 1998, 1999 when I was 20 years old, and back then, because I have flexible joints, okay, and after they told me that this is Ehlers-Danlos syndrome, so nobody could understand, and if I have any RMD, because this is not normal for RMDs to be very flexible. I wasn't having bamboo spine. Even I was with symptoms 5 years due to the flexibility of Ehlers-Danlos. So it was difficult to get my first diagnosis. And after the diagnosis, I didn't have, let's say, a remission, as we talked yesterday. For the remission, I didn't have a remission for many years. And even though I start biological treatments, after 3-4 years that I get the diagnosis. In the beginning, I start taking corticosteroids and anti-inflammatory drugs. So this gained me more than 20 kilos. I used to be on extra small, and in about 6 months I went to large size. And this was also very bad for me because they told me back then, don't make exercise. I used to be an athlete and on gymnastics, and they told me, no, you have to quit, you have to stop, because this will make problems to your joints. So I stopped exercise. I was gaining weight, and I was very, very young. It was just when I finished my studies, and my life changed immediately. And after this, I wanted to get pregnant on my late 20s, and they told me, no, you cannot be pregnant by your own, because I was trying, because you have also problems with your egg productions. So I have to go to IVF solution. I make IVF. I have 2 twin boys now. This took me around 2 years to get pregnant, and then I had to stay another 2 years without medications. So when I deliver my boys, I have to immediately start again medications, because I was in a bad situation. I was lying in the bed during my pregnancy all the time. I had huge pain on my sacroiliac joints, and I stayed in the hospital for around 2.5 months due to my pains. I make suspensions to my twins, and I deliver early. I have 2 immature babies. When I get back to my home, I was not able to walk. I was not able to do anything in the house, and so I had to start immediate my medication. After some years, around 2012, I have some flares, and I suddenly have some pains that they didn't know what it is. This sent me to multiple specialists, okay, and they couldn't find what I had. And imagine that I was vomiting, I was paining, I couldn't stand, and they thought in the beginning that I have something like gastroenteritis or something in my intestinal, an infection. So I left my home. I went to my mother and stayed in my mother's house, and because I didn't want to put my babies into any trouble, because they were premature. Finally, we find that I had kidney infection. And the kidney infections came because I was immune suppressed. So now I am, from 2012, I am under kidney specialist treatment, and I'm trying not to get infections, but I'm getting infections, let's say, quite often in the year. So now I have to take pills to protect my urine system in order not to get infections so much. And also my kidneys have stones. And I have also pain from kidney stones. After that, in 2015, suddenly I couldn't see very well. I was watching on my vision some lightings, some dots, too much dots, and after these symptoms, it came another one symptom. I was watching a circle. Let's say when I was watching a face, I was watching also a circle, like a saint, let's say. And I referred to my rheumatologist, and because I have axSpA, they told me, okay, you have to go immediately to an ophthalmologist because maybe you have infection, or not infection, inflammatory eye. So I went to the ophthalmologist, and he saw that my optic nerve has too much inflammation. Without putting me any drops in order the eye to become bigger, he saw only with the normal monitoring of the eye that my optic nerve is too big. And I had an MRI, I had a CT scan, I had a optic ultrasound, and they found out that I have intracranial hypertension. Intracranial hypertension is when your brain fluid is too much in the brain. And they didn't know why I had this fluid, extra fluid on my brain, but I had to remove this fluid urgently, because if I didn't, then my brain membrane was going to break. Instead of having 15 pressure in the brain, that is the highest normal pressure, I had 40. So they took out the fluid through spine, and thanks God I didn't need to have a cord in my spine, because some people, they have cord in their spine for this. But this changed my life, because I cannot travel alone anymore. I can not drink any alcohol. I cannot take any anti-inflammatory drugs, and I cannot eat anything that contains caffeine inside. So I had to take a huge amount of pills on that time and stay home for around 8 months without being able to drive. And in Cyprus, if you don't drive, you cannot go anywhere. And I couldn't also go on an upper level, that's the area that I'm staying. Because if I was going on an upper level, I had to, maybe my brain was fluid again. And after this was shock for everybody, for my family, especially for me, but also for my family. And after this, in 2016, I begged my doctor to let me go to Maldives, because I love traveling. Okay, and I told him, look, I have to go, I can't stand anymore, all these doctors and things, I want to go somewhere to relax. So we went with Stavros to Maldives. When I stepped into Maldives, I started having diarrheas. And I was thinking that, okay, it's because I changed the water and the climate, and okay. When I went back, again, the diarrheas continue for a long time. I was waking up early in the morning around 3 o'clock with huge pain on my belly, and I was lying on the bathroom floor with a pain. I couldn't move, and the gastroenterologist make me colonoscopy, gastroscopy, and he was telling me, maybe you have celiac. Maybe you have celiac disease. Okay, 6 months without any celiac. It was not celiac. Then, maybe you have another thing. Maybe you have another thing. And I was telling him, I have Crohn's disease. And he was telling me, no, you don't have Crohn's disease. The colonoscopy doesn't show any Crohn's disease. And I was telling him, I have AXPA. I have 60% possibilities to have Crohn. I have Crohn. No, you don't have. 3 years. 3 years was going like this. And then I went to the rheumatologist and I told him, look, I have Crohn's disease. I'm taking medications that are not for Crohn's disease because I was on a biological treatment that is not for Crohn. That biological triggered the Crohn, okay? And the gastroenterologist insists that I don't have Crohn. And I told him, send me to a gastroenterologist that making a capsule test. A capsule test is when you're taking a capsule with a camera and it's going to all the way, okay, to videoscope what's going on. And I went and I had Crohn. So from 2018, 19, I get the diagnosis of Crohn. So I had to change the biological treatment that I went well with AXPA, but triggered the Crohn. And I changed it. And then I changed another biological treatment because it didn't work, and then another one, and then another one. And now I am on the, I think, 10 biological treatment. Not biological, now I'm on JAK inhibitors. And in addition, I have osteoarthritis. I have fibromyalgia. And the thing is that I am a very knowledge person of the diseases and symptoms and all of this. So I knew what to do and how to react. But if a person that doesn't know anything about all of these things, first, it will suffer for many, many years. Second, it is not easy to manage all of this because you have to manage all of this. In addition, I have also insulin resistance. I have problems with my thyroid. So it's a huge package, and if somebody is not so empowered to deal with them, then it's very easy to get depressed, and it's very easy to dive into the problem and not finding any solutions. This is my story life. So, thank you. So the problem is that, for me, is that specialists, they are not communicate with each other. They are not collaborate with each other. They are having the patient like a ball, like the tennis ball. Okay, today you are here, you are talking to me. Then go to your rheumatologist and say that. And go to your other specialist and say that, and say that, and say that. But if I am not a very well-knowledge person with health issues, then how I will deliver correct the things that the specialists are saying me? And how I will manage all these treatments? And many times, because they are not communicate, they are giving me whatever treatments. And I forgot to say that my intracranial hypertension came due to a lot of medications. At that time, I was taking methotrexate, sulfasalazine, biological treatment, anti-inflammatory drugs, opioids, and corticosteroids. I was taking everything that the rheumatologists are giving. So I had high percentage to have something to, yeah, yes, Ingrid.
I have a question. Like if you look back in your history, like how are your feelings and would you change something, or are you, like the doctor did what they know by this time, the best treatment? What, if you look back, what, could you make something different, or you, how are your feelings about the treatment and the cause of the treatment?
Yes, first I wouldn't listen them to stop gymnastics, because that was my passion. And okay, regarding the treatment, but back then I didn't have so much knowledge on treatments and on medications. So I was done whatever they told me to do. And back then I wanted to help my kids because I have a disabled son. So I had to be well to look after him, to care him. So I don't know if I was going to say no to medication, because at that time I need something to go on. Yeah. I would have changed some doctors.
Now you know.
Yeah, yeah.
Maybe
But-
ask more questions also.
Yeah,
Like Mini also said, to be the
Yeah.
empowerment, to know what is going on with you
Yeah.
and what you can do. Like you asked, after 12 years, you asked, I need this
Yeah.
one. Then you were too informed enough
yeah,
to know that you can, like what is happening. So.
yeah.
If I can just add, but one thing which I've realized now as I've got more senior, and you mentioned it as well, is that when someone is first diagnosed, they are shy, they are scared. Scared is a big one. They are scared. I just told them they've got a chronic disease. And I think still, unfortunately, a lot of people feel the doctor is telling me something, I must just do it. I don't want to question anything. And unfortunately, like, I can't go around and change everybody, but opening up a channel of communication from the clinician side is really important, so that they know that you can, because you clearly didn't feel you were in a position to be able to question your doctor at the beginning, and that's very sad. And yeah, I'm hoping that with the new generation it's now changing a little bit, but yeah, I think when people are frightened, they just want to fix the problem.
Back in 2000 in Cyprus, we didn't have any health system.
Yeah.
So we didn't have, we weren't obligated to go to a family doctor in order to refer you to a specialist. It was whatever you think you will go by your own.
Yeah.
So it was not so, you didn't have any directions. And this was difficult because my personal opinion is that the family doctor, it's a must. But again, we have to learn to talk to the doctors.
Yeah.
Yeah.
Well, if I may add that in some cases, at least based on my experience, doctors tend to be, at least the older generation, too directive towards the patients. If you question someone, if I'm 25 or 30 and try to question a doctor who is 65, for example,
Yeah.
they wouldn't even comment on my question, or that's an order, take that pill and no more comments.
Or they make it sound like they're ordering you, even if they don't mean it,
Yeah.
which is equally
They do
bad.
mean
It's
it.
equally bad.
They mean it.
Yeah, well,
What they mean.
Yeah.
They're questioning them as I have read something on the internet and I don't have
Yeah.
at least a medical degree yet.
But the younger doctors are more open.
I mean, it's a sweeping statement, but I would hope that, yeah.
I can see the difference.
And the other thing is that other doctors are avoiding. I have been to, due to my Crohn, I tried to find a good doctor in order to have good communication for biological treatments, to be able to talk with my rheumatologist and find solutions. And I went to a gastroenterologist, but told me, no, I cannot treat you. You have to go somewhere else. Or now I have problem with my shoulder, and there are the orthopedics are refusing me to fix my shoulder due to my comorbidities.
Oh, okay.
But come on, I will stay with a problematic shoulder because I have comorbidities.
It's better to refuse because of the risk
But
they don't know.
You can always take second opinion.
I took for my shoulder 6 opinions.
And they all say that.
Only one said, okay, I will try to help you, and I will collaborate with other doctors to help you.
And it's when you get to that point, you then start thinking, well, what if? What if, something had changed in the past and then I wouldn't have the diabetes or the, or anything else really. You start thinking, well, what if I'd done this? What if I'd done that? What if someone else had done this? And then, yeah.
I think it is a lack of communication between.
This, I think, is, we both said, yeah.
Of country.
I don't know what the solution is to that because, yeah, I think because communication in any walk of life, it requires a two-way dialogue. So I can keep banging on the door of my colleague, but if the door doesn't open, then I'm a bit stuck. Usually then I go to a different door. But then it's a two-way conversation, and I don't know what the solution is. We have 20 minutes?
Yes.
20 minutes for, Andrea and I have prepared some discussion questions, which I'm quite happy to write about. And sort of, based on what we've said, just a chance for you to talk now and share some advice with everyone, if you have any, about the first question would be on tips, routines, or other support that have helped you manage having more than one autoimmune condition or comorbidities more widely in your daily life. And then hopefully we can put together a spider diagram to share with the group afterwards. Just feel free to shout out or, yeah.
Maybe a psychological support.
What kind of, if you don't mind sharing, when you say psychological support, because that can change from person to person, what's helped you, if you don't mind?
When actually,
You mean going to a psychologist?
medical
Or
psychologist or psychological, yes, but the online support too, psychological support.
Yeah, because quite a lot of it is online as well, yeah. Okay.
Also participation in online patients group where everybody shares their experience. And
A bit like this. Yes.
Like this one, which is
Support
now.
group.
The support online is, became with the COVID for us, and then is we get to.
I'm thinking about the Facebook groups or forums
okay.
where everyone can ask questions.
Increased after COVID, I think.
You don't have support groups.
Yeah.
People meet with each other.
With each other, with the
Yeah.
people with the
With
same
the common-
common diseases that they share.
How do you feel about, did anybody used to go to face-to-face groups before COVID, and how have people noticed, have they come back, have they changed, do you miss them? This is something patients tell me, like why is the support group not back, and I don't have an answer for them.
I can add something else. We got a dog,
Okay.
which I realized that it helps me a lot with walks. daily.
Yeah.
You have to go out twice a day at
Mm.
least. Yes. And I force myself to make a bit longer walks.
You have to go at least twice, morning and evening.
Yeah, morning
Mm.
and
At
evening.
least 10 minutes.
At
you know.
least 10 minutes
Yeah.
walking, no matter of the weather, because okay, here in Greece it doesn't get frosty, but in Bulgaria when
Yeah.
it's minus 15,
Yeah.
I can't.
Also the emotional support
Yeah,
and
the
the
emotional,
distraction as well.
Distraction.
It distracts you, hopefully, from other things that are going on. Yeah.
And you have always somebody to hug.
Mm,
You have a
yeah.
dog, yeah.
Yeah.
Yeah, they're always in a good mood. Always listening.
Yeah.
And sometimes they're not.
Never react, but
Family support is very
Hmm.
important.
yes.
Have an hobby.
Sorry?
An hobby.
Oh yes,
Hobby.
yes. Oh yes, I wanted to mention this actually because you mentioned about gymnastics.
Yeah.
So I don't know if anybody else has had this experience with their clinician, but whenever I'm discussing a new medication with somebody, I'll say to them, what do you want to go back to doing that you used to do, rather than, you know,
Yeah.
would you like your joints to swell less? Because that's the way the doctor is thinking, because we're counting your joints, but actually you are thinking, oh, I want to go back to playing golf. That's the one that I hear about the most. Playing golf, or like, you know, going running or gymnastics. And that's then at least then you have a common goal, and you can write it in the, well, I write it in the letter that is the common goal. That's what we want to go back to. Even if it's not 100%, at least we can see you're getting better then.
Back in 2000,
Yeah.
everybody recommendations were don't do exercise.
Hmm.
And in 2010, it started going like you have to do exercise.
The other way. Yeah.
Yes.
Yeah.
Yeah.
But
I believe that must be change of the mind.
Mm.
mhm. Mindfulness.
Mindfulness, yes. I have already, it depended to three pillars:
Mm.
psychological condition, physical condition, and the diet.
Mm. We should put that on because
I
that's.
have, it depended about 13 years before.
Yeah.
Now, with my doctor. Now, I continue every day seeing and training. And now I don't take help. Only some paracetamol, some,
Mm.
but I try very much.
This is a very good example of the impact that
It's very
other
important,
things. Yeah.
3 pillars. But
change the mindful first.
I can add mine. So for me, like there are also all the things you have to think what you eat, how you move, and how you keep your mind. So it's, for me, it's walking with the dog in the seaside or the forest. It's like a daily. It is a little bit of the, how to say, it's not only physically. I don't know how much I can walk, but I will take the car to the parking and walk. But it's also the calmness of the forest or the sea, and also it's a good combination. And really, this is yes. After the work, I said, okay, today I close my computer. That's it, and I go to the forest. This will like help me. Yes, total therapy. And the other, when I have really pain, so for me it's muscle training and stretching. Means even in the street. If my back is killing me and I cannot go further, so I'm just doing my exercises, what my physiotherapist taught me. Also in the concert, when you have to stand, you can do with the music your exercises.
Yeah, it's true.
I tried, it's working. So I think these are important, and also these, I have my therapist, my Ayurveda therapist and my back therapist to help
So complementary therapies.
Yes, complementary therapies, definitely. And hobbies. If I do my gardening things, I adapt it, but it's also you do with your hands something. So you forget all your pain. Okay, you do one thing, but like if I do gardening, I do 3 different things at the same time, because I have to switch the positions. So
Yes.
I do one, then I go to the other place. Okay, my mom says, what are you doing? I said, I will finish, but just I need to change my positions to be able to do it.
Yeah.
So but this gives also these hobbies and life.
I think these obviously are for anyone living with an RMD, but like I think it becomes even more important when you're managing multiple things and you just need to get away from everything, like having the dog you were saying and like mindfulness.
You need to do things that you love.
And yes.
Yes.
Yes. I can maybe go to the, probably only have time for one more question, right?
Yes.
Got 10 minutes.
I would like to
One more?
raise a point.
Yes.
Do you have, because you're going to so many doctors, every doctor is giving you some kind of medicine.
Yeah.
Do you have in your country, there are special doctors that will tell you there's overlapping of the medicines? It's very important. It's very important.
So,
Because sometimes they tell you after this medicine, chuck them away. Just make them uneasy.
On my story is that yes, they don't, they never told me stop this medication.
Because
They
they are
actually, they are,
Always add another one.
yes, but they are looking if the medication is doing with the other one. On this, yes, on
That's
this,
very important.
yeah, on this they
There was
do
a
it.
specialist in the
Yeah,
States.
yeah. And now that I have nystagmus is a condition of eyes, then I found a very good eye doctor. Like she look everywhere for my medications if I'm doing something with the optic nerve and the muscles of the eye, and she was very good on searching, the side effects of the medications and all of this.
I think when you have it doesn't necessarily need to be a primary care physician or, could be an eye specialist, could be anybody, but sometimes someone has an interest in having a look and then you get lucky. One thing which I've noticed in the UK at least is that for our older patients with RMDs, they are often under a geriatrician. And the geriatricians are very good at looking through the whole list, because that's their job, looking through the whole list and then deleting things that people don't need. What I would like to see is that for younger patients with RMDs. And I find, so in the UK, as a rheumatologist, I have to train in internal medicine as well. So automatically, we are trained to think like this in our clinic. The problem is that if a prescription has come from a different doctor or from the GP, I'm not allowed to change it. I can just make a recommendation and then I have to just pray that someone's going to read the letter and do the recommendation on the other side. So it's tricky. Traditionally, the GP used to have that role, but I think in a lot of At least in the UK, you don't see the same doctor twice anymore. You don't have that family doctor thing that you used to have. So, but yeah, it's difficult.
We have the family doctor.
Fine.
No,
But
they
yeah.
are not doing this because
Yeah.
they don't want to.
Get involved.
Yeah.
Yeah. We have a little bit of time for a second question. Do you want me to do this one or do you want me to go to the patient organisation one? 10 minutes. Perfect. Should I go to the patient organisation one or I can do this one? I think we've talked about this one quite a bit.
Yes.
Yeah. Okay. If we then go to thinking about like external people and patient organisations that have helped you, maybe just share your experiences about, particularly because we're at the Agora conference, how have patient organisations maybe helped you? When did you get in contact with them? Like, was it quite early on in your experience? Was it later on when something else happened? Yeah, share your experiences. You can just say, and I will listen.
Support groups. They organize support groups.
Yeah.
But first of all, from the patient organizations, you can say information and correct information.
Yeah.
Changing information.
Yeah. Yeah, this is the real information. I mean, what is the disease, what are the treatments, and so on. They are helping you to get to know with your disease, and then it's changing information.
Years ago we did the Young Paradise strategy, and we also had a big survey about young people needs in Europe. So it was also reversing that information and also to meet your peers. And again, to understand, this is information also to know what is going on with you, where to get it, how to manage and all this. But yeah, but I think also that like me and Andre, we know each other from so many years, but this is also that we understand each other, we can support each other, we know what's going on, you don't have to explain. We said also about the youth group when we started that, we said, okay, we get together, we exchange experiences, not the one who are complaining. Like if you get a healthy friend, then you are again talking about your...
They can't understand, yeah.
Yeah.
So it's a safe place.
And I think accepting as you are, and you're all
Also advocacy in the face of the healthcare systems. I would say that thanks to Boriana, around 10 years ago, in order to get a biological treatment, you had to spend 2 full working days standing in a queue somewhere, either in hospital or in the health insurance fund. Today, when I renew my biological, it's just one visit for blood, and then everything happens behind the scenes. It took 10 years, but still improvements are there.
I did my thesis about access to health in the rare diseases as lupus. So it and the outcome one was that if you are one person and ask for something, no one is listening. But if you are more people, same message, then it will be not pleasant for the politician, and they want to be popular. So they make the decision on your favor.
Exactly.
So that's why we have to be united. This is what we have.
Sometimes we will motivate persons to spam the politicians with multiple emails about something, because sometimes we are not heard as a single organization with one official letter, blah blah, nobody cares. But when you get 50 emails or messages about one cause, then they start thinking.
Also, meaning is that patient organization can inform you about other conditions also.
Exactly,
It's probably,
because they are inviting speakers from other from other specialties, not only rheumatologists, and so they are helping you to understand better why this happens to you, or you learn symptoms and you have in mind that maybe this will happen to me.
It's the self-management also, how to self-manage yourself.
From my experience with this organization, in my organization, we have a few social groups. I want to, led by a social worker. Let's say we made a one for lupus, okay? Special, all the girls, all the girls, only for lupus. Then there was a big quarrel between the girls because aging. So we had to separate the younger one into the older one. So we had two lupus social groups because of the aging and the problem of the aging. So it works very well. Today it works very well. Everyone wants to meet another. They're changing views, of course. Everyone changing problems. They meet together with each other after in the free time. But that was my main problem.
Okay, thank you for your contributions. Is there any last minute questions? We have like 1 minute, I think, now, and then we're going to need to go back in. Or any final comments from anyone? Okay. Well, I hope you found it helpful to discuss, and I'm happy to share my slides with Agora if they want the slides. Thank you.
Thank you. This is for you.
Oh,
Awesome.
match my earrings.
Yeah. Dimitri, photo.
Maybe like come a bit.
Do you want me to turn this off? No.
Here, yeah.
Okay.
That's fine. Amazing. Thank you.
Thank you. Thank you, Andrea. Thank you. Thank you.
You can take a coffee and 10 minutes we will be inside.